So those higher rates of suicidality are shown in patients with mixed mania are shown here on this page that we're looking at. So this was used looking at chart reviews of about 184 adult inpatients with bipolar I disorder, looking at past and current suicidality. And during the index episode, about 57.9% of the patients with mixed mania were suicidal, compared to only about 1.3% of patients with pure mania. So suicide attempts before the index episode were also more common among patients that you guys see here. So about 36.7% among those patients versus 8.2% in individuals with pure mania. Therefore, past, current, and recurrent suicidality were significantly more common among patients with a mixed mania than pure mania. And these findings are pretty consistent with reports that have been seen in the past with individuals with bipolar disorder who have mixed mania than among those patients with pure mania. And multiple previous suicide attempts may reflect also more severe lifetime illness, and patients with mixed mania in particular may especially be at risk for non-recovery, treatment failure, comorbid illness, and poor outcomes. These features, perhaps even more than current suicidality, may collectively predispose these patients with mixed mania to treatment failure. And we'll look at treatment efficacy on this next slide. Looking at the treatment efficacy for individuals with mixed states, we see that the data is unfortunately limited. Despite a lack of controlled trials of adjunctive antidepressants during manic, hypomanic, or mixed episodes, most clinicians really tend to avoid using the antidepressants during the mixed episode. And that's for fear of worsening the mania and without improving mixed state depressive symptoms. So looking at a study of a large insurance database claims of antidepressant treatment, over 32% of individuals in this study, looking at over 2,000 individuals with bipolar I disorder, following a recent manic or mixed episode, more individuals that were on the antidepressant had higher rates of hospitalization during a 12-month period. And antidepressant treatment in bipolar disorders is sometimes associated with new or worsening irritability, agitation, maybe new onset of insomnia, impulsivity, and suicidal ideation. When we look at the mood stabilizers, we see that although lithium has been used for more than 60 years to treat bipolar disorder and remains the gold standard for mania, it's thought to be less effective when mania and depression occur simultaneously. The second generation antipsychotics, they can be effective, but then the risk-benefit ratio for side effects has to also be looked at. Dr. Ketter, any thoughts on this slide here?
Yeah, so broadly speaking, antidepressants can cause some mischief in mixed states, and they can cause conversion of a pure state to a mixed state. And that is something that should raise the index of suspicion. The mood stabilizers, it's remarkable how little we know about those in mixed states, except for lithium, which has shown to underperform a little bit in mixed states. And the second generation antipsychotics, we're just beginning to get a sense of some of the differences between these agents.
Right, so definitely more work needed to be done. We'll go on here to our next polling question. So based on your clinical experience, what percentage of your patients present with DSM-5 mixed states? So A, 0 to 10%, 11 to 30%, 31 to 50%, or D, greater than 50%. Dr. Ketter, while the results are coming in, where do you think the numbers lie?
So, you know, different clinicians have different perceptions of this. DSM-5 has been criticized for being too exclusive in some ways. And in that regard, the percentage could be a little bit lower than is desirable. And you want to figure out what is the desired percentage and what is the actual percentage.
Right, so we see the results here that about 40% of individuals say about 11 to 30%. and then followed by about 31% of individuals say 0 to 10%. So we're looking at anywhere from about 0 to 30%.
So that's not too bad, actually. My personal prejudice is that, in fact, it's a little bit too low, and that from 0 to 10% is too big a proportion.
Right. So if we look at the next polling question here, based on your clinical experience, what percentage of your patients should present with the DSM 5.1 mixed state?
So DSM has developed the use of Arabic numerals so that you can have DSM 5.0, 5.1, 5.2 to make it easy to modify this as we go forward, as we move forward in time. And this question is essentially asking, what is the desirable percentage of people with mixed states? You want enough statistical power to be able to do this. And so in this particular analysis, you got 47% with 11 to 30%. So that's a little bit better than I would have expected. I would have expected the 0 to 10% to be low, and it is the lowest. Mm-hmm. I would have expected, this 11 to 30% is about correct. Okay, and the 31 to 50%, you would expect that could be a little bit on the high side. So the mixed feature prevalence in bipolar disorder ends up resulting in heterogeneous symptoms and making diagnosis more challenging. And Trish Supis has looked at women with milder forms of mixed states and has found that there's an excess of that. One way of understanding that is women get more than their fair share of depression in the bipolar world as in the unipolar world. So even though the number of women and the number of men affected by bipolar disorder are similar, that's in contrast to major depressive disorder where women outnumber men. Even though in bipolar disorder it's a similar number, there's more female depression, and thus when there are mixed symptoms, women are more affected. And so over on the right there are some results of a Depressive and Manic Depressive Association survey of 600 patients. And they reported that misdiagnosis was very common, and only 20% were correctly diagnosed within the first year. So this can be kind of daunting. There can be comorbidities, there can be mixed symptoms, there can be all kinds of things that make this more complicated. If patient has mixed symptoms, these symptoms may end up getting missed. Patients who have a lot of irritability and depression as their main symptoms, they could be considered more depressed than anything else, and the mixed features get missed. And so this is looking at how inclusive DSM-5 is. And you can see that this was a sample of 153 patients with mixed features and a depressive episode. Okay, these are all bipolar patients. These are from our clinic, and you can see that the DSM-5 approach was less inclusive. It only included 7.2% of patients having a major depressive episode with mixed features versus pure major depression. And we tried broadening this out by using the European construct of permitting so-called non-overlapping mood elevation symptoms as well as overlapping mood elevation symptoms. So one of the reasons that 7.2% is so low over on the right is because they have not allowed irritability, psychomotor agitation, or distractibility to count towards mixed symptoms in depressed patients.